right, welcome everybody to another episode of My Good Friends. We are live with a number of leaders, and we are wanting to talk about kind of COVID, or the virus that shall not be named. I like to refer to it as, and its impact on revenue cycle. So on the phone, we have Heather Dunn from Vanderbilt. Heather, say hello.
Hello.
Kelly, I'm going to mess up your last name. Kelly, you introduce yourself. That's better.
Hi, I'm Kelly Kloeckler. I'm with UT Southwestern in Dallas.
We go. And Scott.
Hi there. Scott Williams from Duke University.
And my co-host, who needs no introduction, Tina.
Always here. Always here. Hey, I put on like a pretty top today. And jewelry. I feel very
the shirt is, if only Heather could see the shirt, she would be really happy about it.
I would be so impressed. I'm sure, Tina. You're always so well dressed and put together. Make Ben look good. Make Ben look good.
Someone has
to. I was going to wear what Ben is wearing, which for a podcast, it's not really very effective to talk about, but I was going to wear my RCM jacket, but then I thought maybe
the coveted jacket. The
clothes that I keep buying, even though no one can see them.
Well, if Kelly and Heather would join our advisory board, they get a jacket too. So I'm just saying, there's pluses. Pluses. Not many, but that's one. There's not many.
Free jacket.
The free jacket. All right, so I want to kind of get a round table. It'd be good to hear from everybody, like, how has the virus impacted everybody? I know, Heather, you were just saying like you had to send 600 people home in 24 hours. So why don't you guys just start, like, what's kind of the number one impact for everybody? I'd be curious to hear. Heather, you go first.
I'll go. Okay. So I think the biggest impact was, well, let me talk a little bit about March in Nashville. March in Nashville started out with a massive tornado that tore through Nashville and the surrounding towns.
Right.
It was an F4. It hit multiple counties. It was terrible. That was the first thing that happened in March. And then the COVID thing happened in March. And deploying people home, we started setting up assessment centers on the fly. We converted the first floor of a parking garage into extra space for the emergency room. Within that, I mean, literally a garage. It was the first floor of our garage as an extension of the ED. We put in assessment centers. We shut down all of our Walgreens little nurse practitioner clinics, 14 in the area, redeployed nurses to walk-in care just to do nothing but start giving out COVID tests. And that was great clinically and operationally that we were able to pull that off. From a revenue cycle perspective, that was a lot of things happening in environments that were not normal. So I had nurse practitioners who are not, who the payers don't know, are paying on different contracts, doing different work. We had charges that were being set up in the system that we didn't know about in the revenue cycle that were for these new tests that we were starting to perform.
Right.
So basically we started this huge, massive clinical operation to serve the patients of, Nashville and surrounding areas, and we're now, in revenue cycle shortly after that started to feel the effects of kind of the fast pace of making all of those things happen quickly.
So Heather,
so we've turned into the cleanup crew.
Can I ask a quick question, a technical question? Because I'm curious on Epic. Did they just use like a location that already existed, or how did they even do that within so they added new charges? Let's say they went from, I don't know, an outpatient clinic to something else that's brand new. How did you guys even do that?
So one of the things that we started using in Epic was called event management. So here at Vanderbilt, we go to a lot of, we'll take the CMA Awards. We have a tent set up at the CMA Awards. We use this module called event management. We see people come into the tent, they're dehydrated. We might give them some fluids. We take some basic information.
Gotcha.
We were doing that on paper a few years ago, but Epic allowed us to use a module. However, that module, we quickly found out, didn't collect insurance information. and it had very scanty kind of documentation requirements in it. So you could basically say, a guy came into the tent, gave him hydration fluids. We weren't going to bill for that anyway because the CMAs paid us a flat rate to be there. But we started using it in this emergency, parking garage situation. And so we were giving out COVID tests and evaluating patients kind of like a sit-down, drive-up type of situation, and we weren't charging for it. And we didn't have any insurance information. It was just being documented in the system. So that wasn't fabulous. But we've since then kind of gone back to the drawing board and fixed a lot of that. So now we have a more robust event management system. Otherwise, we use the same departments that we've always had.
Interesting. Scott, Kelly, do you guys know about that? I've never heard of that event management module.
We don't use that either, but similar to what Heather mentioned there, I think you set up, depending on your reporting and billing, for us, we set up a couple of new DEPs, departments in Epic to track that separately. And honestly, the easier part from a revenue cycle perspective is capturing that. The harder part is then figuring out all the new payer requirements for how they want telehealth and COVID services billed and all the rest of that.
Did you have provider enrollment issues, I'm assuming, just because they were in different spots?
I had enrollment issues because our Walgreens operation is part of a joint venture, and my walk-in clinics are part of Vanderbilt. And so those are separate contracts.
Right.
Although it feels to the public like it's one thing, those nurses coming over and crossing that, kind of border just means a lot more effort on the payer enrollment side to get them all enrolled, which takes time. And it's only been, 4 weeks. Although it feels like an absolute lifetime, right? We haven't solved that problem just yet.
Right. Scott, what were you going to say?
I was going to say, I think for each of us, it depends on what our local payer environment is and what their requirements are from an enrollment perspective. So in North Carolina, we didn't have as much of a problem with moving providers around to different locations. Our biggest constraint payer was North Carolina Medicaid, who relatively quickly relaxed all of that, somewhat surprisingly, but happily we're good to see that. So we haven't seen that much problem as we've had to move providers across the Duke Health footprint.
We have a small footprint. The only thing we looked at for provider enrollment was how do we get the hospital-based therapists billable so that they can do telehealth. So we were looking at enrolling them under our professional tax ID. So getting them out of the hospital so they could do some telehealth as well.
Yeah. Wow. Well, Heather, it sounds fun. Sounds like you had a good time in March.
Yeah, I think what's different about academic medicine is, we developed our own in-house COVID test pretty quick, right? And so we've been doing the test and the evaluation since day one. And so I have that kind of bucket of claims, and then I have the bucket of the telehealth claims. And what I've found is I don't think everybody was doing that. I don't know that institutions across the country, academics or otherwise, set up these assessment centers in the way that Vanderbilt did to kind of, start to serve the public long before, states were setting up testing sites and things like that. We kind of got ahead of the game. So I actually just emailed the group of us in the forum and said, is anybody getting paid so far for any of these COVID related visits? Because I've sent out a sampling of accounts just to see how the payers were going to pay them. And the feedback has been interesting.
Well, we've been very slow to release claims because just the other day there's modifiers that CMS released that have to go on to the COVID tests and then any E&M visits that were associated with them. And then there was another thing that came out that Medicare would pay more. So then you had to go back and look at your equipment and see if you could change the CPT code on the test. So we have been very slow to release any charges because every day there's something else that you have to put on there. And then I also didn't want to get a bunch of rejections because the clearinghouse didn't have the code set up. The payers didn't have the code set up. So we haven't released very much at all.
We're in the same boat there in terms of now that Medicare has finally released, what they want, CS modifier on the outpatient side with the tests, but nothing on the inpatient side. So today, actually, we're releasing the inpatient and outpatient Medicare COVID-related claims, but are still holding up all the other payers because we don't feel like we've got enough clarity on for COVID. Same sort of thing, but undoubtedly we all have been working through with telehealth. It's great that we're all, much the same way in terms of we sent everybody to work from home in a short number of days. Suddenly, after decades of being slow to improve, telehealth coverage,
Right.
they can't help but fall over themselves in terms of
Right.
supporting video and phone and e-visit and all the rest of that. But it's coming in at such a fast flurry that trying to get some consensus on what the rules are so we can start billing these things has been challenging. At the same time that we're all so short on cash that there's a lot of pressure to get that stuff out the door to try to alleviate some of the cash pressure we're under.
Yeah, I think the telehealth thing has been really interesting. I mean, there was a couple of days and still to today that we were iterating on Medicare guidelines coming out multiple times a day, right? I mean, and I agree. I'm still holding all those telehealth claims. The ones I released were the early rapid flu E&M with a COVID test on the professional side. I wanted to see if the payers were actually going to waive the cost share, because there's so much commotion about this being quote unquote free. I mean, President Trump stood up weeks ago and said free tests, right? Nancy Pelosi, free, everyone go get their free test, and it's not free. And there's nothing that says that it's going to be free. The cost share piece, I was a little bit concerned that the payers wouldn't be able to actually execute on all of those wonderful statements their CEOs are making in the news. And so I took 20 claims from Cigna and I just sent them. And I put a big fat safety net up in Epic so I didn't bill the patient, but I wanted to see how the claims were going to adjudicate. I went out, we combed their payer website. We figured out what diagnosis codes and modifiers and all of that they wanted on these claims, and I sent 20 of them. And more than half came back with a cost share.
That doesn't surprise me.
And the concern for me is not so much that they have a cost share. It's that if I were to pass that cost share on to the patient, patients are not going to go back to their insurance company. They're going to think that I did it. They're going to think the hospital did it. And I didn't. I'm only passing that information on. That's my first concern. My second is that, I think our institutions have had to attest to not passing cost shares on in order to get some of the recovery dollars. And that responsibility falls squarely on our laps now, even though the payer, their adjudication systems are clearly not updated, as I have just proved, right?
Yeah.
So I put the COVID diagnosis on there. I put the CR modifier on there. I put everything on. They got the test. They got the records. They got everything. And they still adjudicated it with a cost share. So it's kind of a warning to my revenue cycle friends in the world. You're good to
you'll
hold
end up
on
on the
your
news. And the hard part is you'll end up in the news, right? There'll be
I
some
already
investigative
was.
reporter.
Yeah. I mean, Google Heather Dunn, News 4, Nashville, a couple weeks ago. I was in the news. I was already there because I didn't have the safety net set up fast enough. And I did accidentally, we sent out a few walk-in center claims for people who had early COVID tests. I mean, early May, or early March. I think the dates of service were like March 11th. And that was before we could scramble with our health IT teams to hold all these claims and hold all the statements and put on, these, because everything that we do in revenue cycles, all Epic driven or technology driven. I can't hold claims by myself. I have to have those, those systems built to do it. And we didn't react quick enough. We sent out some claims and the patients ended up with copays and they went directly to, the news.
Well, and I think it's also a little misleading too, because a lot of the ERISA self-funded plans may or may not waive that portion. They weren't required to. So, I mean, if we have Blue Cross Blue Shield, we don't have a Blue Cross Blue Shield separate plan for every self-funded plan out there. So there could be some cost share that are
Right.
from the ERISA plans that will still be, and then the patients are confused because Blue Cross Blue Shield said they were going to pay for everything. Well, your employer decided not to for whatever reason. So that's another concern.
Yeah, the only advice that I can give about any of that is, you know, we're starting to think through how we educate patients about the reality that is behind this, you know, curtain of the test. Everything is free. COVID-related visits are going to be free, and the test is free. And so we're trying to take a patient education kind of perspective and start thinking about what we can put on our websites, what we can put out into the world to help patients understand how to read their EOB, what the rules really are. That's hard because I don't have all the answers to what the rules are. I certainly don't think that payers are all on the same page about what the rules are. But that's the best I can do, is to arm our patients with information about what's really happening. I think not doing anything might lead us in a place where patients don't understand, and then they're confused, and they're on the offensive, right? They start to attack the health system or, you know, the hospital in itself for sending them a bill, right? And I'm trying to get ahead of that. I would love to hear from you guys about if that's the right strategy or what strategies your organizations are taking, but that was the only thing I could come up with on the fly as I started to see these claims coming through.
I mean, it always feels like, I'll just weigh in real quick. It just feels, I've always been like redirecting the patient back to their own insurance carrier to ask those questions. But the challenge with that is always, then you're redirecting them back to somebody else, and they may not, want to do that. But it's certainly, like, you're right. You said earlier, I think it's on the payer to like do what they should or shouldn't be doing, and then explain that to their members. But it's so confusing, and they're probably not doing that.
Yeah, we're being very conservative. So we are holding pretty much any claim that has a COVID diagnosis or a COVID related diagnosis, which is a pretty broad group of claims.
You're just holding them, Kelly? Is that what you're saying?
Yeah, we have a statement hold on all of those. So they'll basically start collecting in my self-pay AR until we can follow up with the payers and make sure they adjudicated it correctly.
Yeah, that statement hold, I think, is critical. We put that up, but and yeah, that's going to be another scary thing for hospitals. We're going to end up with this, I'm afraid, a patient liability bucket that's pretty massive.
Totally. And are you routing that into like a new work queue? All those claims go to new work queue in Epic, is that right?
Yeah, we just have a statement hold, and so based on that particular statement hold, they're routing into a single work queue that will then go back and work anything that has self-pay balances.
I think that's true. And I think most of us have put a statement hold as best we can in that fashion, and are worried about how that plays out there. But let's not kid ourselves that what we're eventually more than likely going to eat right off in terms of patient-related balances on COVID services is a small drop in the bucket, a rounding error compared to the adverse financial conditions we're all going through right now because of lower volume and how that plays out. We'll have to deal with it, but that's other than making sure that we're not billing patients and dealing with the PR perspective, the actual financial cost of eating some COVID-related costs is pretty minor. We just need to make sure we do it right.
Yeah.
Yeah, you're absolutely right, Scott. I mean, I could not agree more. The first thing we started doing at Vanderbilt was get every account that's not COVID related out the door, paid, every denial worked, I jokingly said I was bottom feeding the other day when I was trying to get providers to go back and close encounters and respond to queries and, in CDI, because cash is drying up fast, right? With volumes that are really low, waiting to see what happens with, if the curve is really going to flatten, or if June, all of a sudden we're going to have, hundreds of ICU patients. And I think that's a really scary prospect, right? So we're trying to hold the line with low volumes right now, waiting to see what happens. In the meantime, you got a bunch of telehealth claims you're sitting on. The reimbursement on those is not enough to, to
offset
cover all of
Yeah.
the things we're not doing.
Yeah.
That really is the bigger picture we're all faced with, is it's all volume based. And so I look at it and say, the revenue cycle performance metrics that we take a look at, our DRO, our AR aging, our denial rate, our avoidable write-offs, all of that is still important. But the practical reality is us reducing our denial rate from 5% to 4% or whatever the numbers are. That is a butterfly, floating in the wind compared to the fact that right now most of us, our volumes are down plus or minus 50%. Right? I mean, the last 4 weeks at Duke, and it's probably been pretty similar across most of the major players across the country. We've gone from 85% of norm to 65 to 55 or 50 to 45 last week.
Right.
And nobody has a crystal ball in terms of when that's going to start heading up. But those type of volumes are measured, that the financial impact for most of our large organizations are measured in the tens and hundreds of millions of dollars of impact. So right now, a revenue cycle, I think we're all trying to keep the wheels on the bus going as best we can. And there will continue to be a high amount of oversight as we're trying to make sure, as we get into recovery. But the biggest opportunity for all of us is supporting the clinical operation and figuring out how to get volumes back up to speed in whatever reasonable time frame is defined.
Well, I think with the three of you, you're all really large institutions. I don't know if anyone caught the New York Times as a podcast called The Daily. They did a feature, basically 20-minute feature on a small rural hospital in New York. And it was with the CFO, and the CFO basically figured out she had a week's worth of cash to pay her employees for a week. She had like $400,000 in cash. And so if you think about some of the small organizations, I think that's what's most interesting to me, is like they're the most at risk for just not being able to even cover.
Yeah, I think that's true. The one thing I would say, we talked a little bit earlier about how a number of us, almost overnight went to virtual meetings and work from home and telecommuting. And I look at, at times we complain about the bureaucracy of both our own organizations as well as the federal government to try to get things done. But I look at what's happened in the last 30 days, and as chaotic as it's been, it suggests that when you really want to do something, you can actually do something pretty quickly. You can move your entire workforce to work from home almost overnight. You can get telehealth up and going when it's been kind of hanging out for 2 decades, but now in the last 30 days, all of us are doing a ton of it there. The federal government has issued in very short span, not to get too political here, but stimulus checks and accelerated advance payments, and that came out honestly much more quickly than I would have guessed. Maybe not perfectly accurately, but that is a lifeline that's keeping most organizations going in the short term. There still is a day of reckoning because part of that money is purely handout stimulus, but a fair amount of it is advance payments that you're going to have to pay back come the fall, and then you're going to have to come to grips with the financial implications. But a lot of stuff actually got done really pretty quickly.
Yeah.
I don't know about in your area, but I know the one thing that when we've done some financial counseling with patients, there are a lot of businesses that even though they furloughed people, they still had health insurance for 2 to 3 months. And so that's been very good because we were afraid there would be a lot of uninsured patients that we were trying to figure out alternate means for. So a lot of them did keep their health insurance, which was good.
That's another good point that I think all of us are working our way through, is outside of just the sheer volume and service decreases and how that rolls itself out through the finances there is in every single area we've got adverse conditions for patients, right? I mean, hundreds of thousands, if not millions of patients across the country are now unemployed, which means they don't have disposable income or any income to pay things like healthcare bills and the rest of it. And so we're all dealing with lower amounts of patient payments, and how do we as organizations reach out to our patients to show our compassion, not just clinically, but financially, to provide some sort of relief on financial assistance and delayed payment plans and a variety of different things.
Yeah, I think I totally agree with Scott. I think it's a brilliant statement, right? How do we balance empathy and trying to work with our patients to do things? When you think about bringing back elective procedures, and you also balance that with, I think the other day, what did the news say? It's 1 in 7 people have lost their jobs. I mean, that's going to be hard to do. How do you get those volumes back that we pushed off for a couple of months and still have patients, on insurance rolls? And that should be a really interesting time. I don't know how, that's going to be a challenging balance between what we do for people clinically and how we handle it financially.
Yeah. I mean, there's not even really anything to add. It's like, yes, that's going to be an interesting challenge.
So I think I'm going to go to a bright side of this, is that while some of the volumes have been down, we've been able to engage some staff on some of the back end denials. So I've got my utilization review nurses working level of care denials or inpatient authorizations. I've got my coding group working medical necessity denials. I've got my radiology authorization group working radiology denials. So I've got some of my front end resources being engaged on the back end. And so I'm hoping that after things line out, that will be very educational and beneficial to us long term. So on the bright side of things, that's been positive.
Yeah, good.
That's cool. There's some cool innovation that has come out of all of this. I think I've been impressed to see just the community making face masks for our patients, or we started doing these little gratitudes in Nashville, right, Music City, where people can purchase a song and we play the music through the hospital. And so the nurses and the doctors in the hospital can get free Spotify music where they are, and it's all donated from folks. Or you can donate you can do a little video message and send them a message. I think, and not to mention all the innovation that's happened to make ventilators and to figure out, we're now we have a UV light room that we're using to clean our N95 masks. So they set that up. I mean, I told you guys about the conversion of the parking garage into an extension of our emergency room, 40 beds. I mean, it's amazing to see the innovation. Just in the ED alone, we've got admitting folks that are down there, and we were worried about protective equipment for them. And so in a matter of a week, we purchased some iPads. We used RedCap to create a survey that feeds into Epic. And then we put our admitting staff kind of behind the scenes and gave the iPads to the clinical folks, and they hand them to the patient. The patient fills out all of their registration information themselves. We sanitize the iPad, and then the registrars are now behind the scenes, and they call into the patient's room to get any additional information. The iPad lets them take a picture of their insurance card. It was brilliant because we were just trying to protect and keep people away from anybody who might be symptomatic. But things like that are popping up everywhere. People are so creative and innovative in a time like this.
So it removes the registrar from like having to interact with the patient multiple times.
Yeah, it's basically good. Like the kiosk technology that, when Epic deployed kiosks, it was kind of we didn't do it very well here at Vanderbilt, but this has definitely pushed us to be a lot more creative, like to all of our points, right, about telemedicine. I think we did 35,000 telemedicine visits in the last 2 weeks. We were doing 10 a day prior to this, right? So it's awesome to see the change and really things that are going to stick. Why would I go back to having registrars be face-to-face with patients in the ED? I like the technology of it, right? So we kind of use we have a program called Meds to Bed, right, where patients are leaving and we bring your medication to you, and then we ask if you want to see a pharmacist, and they have an iPad, and if you want to see the pharmacist, it's right there on FaceTime. Here's your pharmacist. Why would I go back to having a person in the room if I don't have to? Be great. Plus, it helps me with retention down the road and lots of other problems solved and protecting our employees. And I like that. I love all the innovation that's come up. I don't know if you guys, Kelly or Scott, have had other similar things happen, but it's been a really cool outcome of all of this.
Yeah, in fact, I was just talking to my director of patient access, and we were talking about long-term, what do we need to purchase to kind of continue some of the things they put in place long-term. And then again, my staff on the back end say, do we have to come back to the office? So we're trying to figure out, what does the new normal look like once this has gone back to whatever normal is? What do I do with all this office space that I have? I have another 5 years on my lease. Do I need it?
Mm-hmm. I'm curious to know what you guys, I was thinking about, we did a webinar for work remotely, and I thought it was, good. It was like, I had some really good thoughts. How is it going for everybody? Like having all your staff at home. Now the genie's out of the bottle. So question one would be, how's it going? And two would be, do you think that will continue?
I suspect for most of us, it's going better probably than we expected, and we've forced ourselves to do that pretty quickly. At Duke, we probably had 3/4 of our staff working from home 3 to 4 days a week, and then like everybody else, we went to 100% 5 days a week, and are working our way through it. But honestly, working pretty successfully. I mean, the things that we challenged ourselves with before about, well, can you really do 100% virtual? Can you hire and recruit and onboard staff and train them and do all the rest of that? And the answer is, yeah, you can do that. I mean, probably not perfectly, but you find a way to manage it such that, whenever this eases up, I think Kelly's right. I mean, most of us probably, at least in our back office and business office functions, are probably going to stay, if not entirely remotely, a lot closer to what we have now than what we had 30 days ago.
Mm-hmm.
Yeah, I think we will too. And I think there are some challenges right now with like childcare and kids being home from school that wouldn't be the long term, and people wouldn't have some of those constraints, and we might be not as flexible as we are right now about when you work, how you work, but long term, I don't see any reason for people to be back in the office.
Yeah, it's forced all of us, I think, to, again, be smarter about how we work from home and how we communicate virtually, and even the social protocols of how to have a 2-person virtual meeting or a 20-person virtual meeting such that you're not talking over each other. And the other piece it's forced us, that we had a lot of people working from home, but we had it was all data and audio. We had very little video capacity. And so, as best the cameras are available in the marketplace, because everybody wants them now, we've kind of concluded that to work effectively from home, you have to have the video component to force people to be more engaged and to engage actively rather than passively. That's a key component there.
Is anyone doing, so we talked about on the webinar, the group that we had who are experts in this, they had created this software called Collab app, but it basically had like teams would have a camera on them all day and they could see each other on the team. So you'd have it all day, like on your screen, you'd have this where it's like, I can see Susie, I can see Deb, I can see Bob, I can see Mike, and they're working or they're on a phone call, but I can message them, but I can see them. And so they were saying that was like one of the crucial things is having like constant, like being able to see everybody. And actually was really helpful. So I'm wondering if anyone's done that yet, because I know that
I think there's two sides to that, right? I mean, the accessibility such that if you want to get a hold of somebody, whether it's Jabber or Instant Messenger or the rest of that is great. I think it's pretty easy to see how quickly you can get into overly micromanaging and Big Brother that nobody wants to have a camera on them at all times to make sure that they're being productive. If we've got to do that to make sure people are doing their jobs, we've got some other underlying issues in how we manage. So I don't know that the 24 hours a day or the 8 hours a day constant barrage is necessary, but I think finding ways to make sure we can communicate easily and effectively, and that can be done in a lot of different ways, is the important piece. That's just my 2 cents.
Well, and I think the reality is Epic provides some really amazing tools to actually monitors people productivity. So I don't know that you have to have a camera on them, but one of the benefits that we've seen is some of our supervisors being able to watch somebody's screen and really watch them work, and really help them with maneuvering in Epic or doing some things a little better. So just that focus on the screen and not on, when you're one-on-one in a live environment, there's a lot of other stuff going on. But when you're remote and you're looking at a screen together, it's been a lot more beneficial to the end users and the supervisors in terms of training. So I think that's been huge.
Yeah, I think instituting some rounding and getting some feedback is probably helpful, right? We've got data that show how productive our employees are. Kronos will tell you, how many hours they worked. Epic will tell you if there's big lags in time where there's no action being taken in the system. And your data in the back end, your results are going to prove whether or not you have effective people working from home. But we started implementing rounding with all of our supervisors and said, every day you have to round with your staff, and we change up the questions and we ask for feedback, And I think that's helpful. To Kelly's point, somebody's having a problem with something, hop on a Skype or Zoom and show your screen and walk through the process. And I think that's going to become critical if we all start to work from home again. It would be, making sure that you're getting good feedback about the things that you won't necessarily see in the data, but your results should speak for themselves.
Well, so I want to clarify real quick. So one of the things that they said was they were not using it to see if someone was working. What they found, though, is that teams that were using it felt like they were much more connected to the team, because they could see Susie and see Susie, oh, let me just send her a message real quick, or I can instantly pull up as a video chat with them. So they weren't necessarily using it to see, like, is Bob working? I mean, you could see that, but it was more so that the people and it's interesting is there was initial pushback, almost every group that's done it. And then what they found was that the groups loved it because they could feel like they were actually because before, if you imagine, I'm in a cube farm and I see Susie and I see Bob all the time, and I just walk up and I walk over there. You can't do that, and you can't see them. It creates this immediate isolation, which some people like and some people will hate, right? So it's just another thought of and they said what's fascinating is they said most of the issues actually come the leaders don't want to do it, which I think is fascinating all by itself. But it could be interesting to test out what that looks like, because it could help with just team being a team still.
Yeah,
I think
that is interesting, and it's spot on. And I totally agree with what Heather said there. We've done the same thing in terms of we've had rounding for a long time, but basically requirement that everybody that's working from home gets a rounding conversation. It might be a minute or two, it might be 10 minutes or more every single day to try to cover that gap of isolation that inevitably most people feel in some form or fashion. It's exacerbated now because we've got the chaos and stress of COVID on top of it. But even if we didn't, working on your own, it can be isolating for most people. And so finding ways to formally or informally bridge that gap, I think, are really important.
Well, the next generation is going to have less and less problem being on video.
Right.
In fact, they're going to probably prefer it. They probably prefer it right now before this all happened. Well, so it could change everything.
To a certain extent they do, but they are not, other than watching TikTok videos, they're not real crazy about talking to a person. They would much rather text, right? And it's no different. My kids would much rather text me than call me on audio, or God forbid, look at me face to face and the rest of that. But I think the fact of the matter is people come in all shapes and sizes, and we got to figure out how to accommodate that.
I'm just impressed you know what TikTok is, Scott, to be honest. That's impressive right there.
Yeah.
I love that my kids are doing the online school thing, and they're little. I mean, they're 7 and 9, and they have not shown a great deal of anxiety. Maybe it's because, they're little right now. They still like us. They still think Chad and I are pretty cool. It's give it a couple of years, they won't talk to us anymore. But we've been able to make this work. And I hear them when they get on a Zoom session with their teachers and their classmates. I hear them say, you know, I miss you and I miss seeing you. But they've done really well. I mean, they've done really well adapting to being on their iPads and not being able to see people, but to communicate in a different way. And kids are super flexible like that. But you're right. Then we are grooming this next generation to be very much. If you work from home, you can do anything, and you can work for anyone, right? So I like the opportunities it will give them in the future. It's just trying to find another way to feed your need as a human being to interact with others. So there's a balance there, but I personally have loved it. I went to the office every day, and I'm just really sad that I have some really beautiful suits that I'm wondering when I'm going to wear them again.
Never. You're not.
It is a big change.
On a Zoom call.
Yeah.
Well, if you had a camera, Heather, maybe you could wear it then, and then people could watch and see your suit. Just an idea.
But it is true about how things have changed. I can remember, joking over the last 10 years that there will come a day in the future where, more of us in administrative type jobs are working from home, and we'll laugh about, remember when we used to get in our car and drive half an hour to an hour to a building and then go in and sit in an office or a cubicle there for 8 hours, and then at the end of the day, we'd get back in our car and drive for a half hour, 45 minutes to an hour. And what a ridiculous waste of time that was. And this has jump-started a bigger push in that direction. And again, it isn't the be-all, end-all solution, but it's a whole lot more of a solution than people probably recognized even 30 days ago.
And you do gain an hour to 2 hours in your day from just not having to go through getting ready for work and driving. And
God, if you live in Nashville, Dallas, your traffic is horrible. So I can only imagine.
Great. I mean, the hard part is turning it off. I mean, because your office is right there. So it's awesome that my commute is down 12 steps, and I actually got to have dinner with my family, several times last week, which was so great. But I also catch myself right after bedtime walking by the office and like, oh yeah, that's right, I got to do this, and go back onto the computer and start working again. And I think figuring out, at least for me, figuring out those boundaries, like, okay, or don't work after this time, or is hard because there's so much going on right now. In revenue cycle in general, you could work 24/7, 365 and still be behind on emails and not hitting the numbers that you want, right? Like, we could just kill ourselves doing this. But there's that work-life balance I haven't quite figured out in the 4 weeks I've been working from home.
You haven't figured it out in 4 weeks? That seems...
I haven't. I'm totally falling behind. I know.
But don't you think,
my peers have probably have it all figured out.
I think that's a limitation of the quarantine, though, because I know if I work from home after work, I would still go play tennis or do things like that, which I can't do right now. So
True.
I would still find other things to do.
It feels, though, a little bit like this is the time. This is really kind of shaking and providing perspective that people hadn't had. So I feel like it is a time that it is evaluating, like, maybe we don't have to have that meeting, or we don't need to, that really doesn't matter that much, or these emails don't work, or email doesn't work in general. maybe it's that point I'm trying to make. It would seem that this is the time that would evaluate some of those things, and they would hopefully fall off. Like, we've all had this problem, Heather, you're not alone in that, of like, our phone is on 24/7, and you could either answer that all the time or not answer, so it feels like it's, I don't know, I almost feel like it's got to be a push towards forcing people to deal with the fact that, like, you can't do it all the time, and doing it all the time makes you less effective.
It definitely is forcing some level of higher prioritization along those, right? I mean, I'm sure I'm not the only one that feels like in the last 30 days, I've spent 90% of my time just thinking and doing COVID-related planning and contingency, and the remaining 5 or 10% of my time doing the entire rest of my regular job. And it has basically, some stuff has either dropped off or it slowed down the process, and then you've realized, well, okay, life's still going on, and what are the things that are more critical to our operations and everything else that goes along with that, and what maybe isn't as critical in hindsight.
Yeah. You hope it's like a pruning exercise.
Yeah, I will say, I'll make a plug, Ben, for our last podcast.
It was awesome.
I will.
It was
you
awesome.
know, I will make a shameless plug for everyone to listen to our last podcast. The first group I pulled together, and actually the first time we all collectively said, oh my gosh, this COVID thing is for real here at Revenue Cycle, and we better get some people together to figure out how we're going to handle this. I was in my park meeting with Brian Rothman and Byung Kang. They were both sitting in the same room with me, and we looked at each other and said, uh-oh. And we have had a daily meeting of the park team, health IT, clinical operations, and Revenue Cycle every day at 8 a.m. for 4 weeks, a little over 4 weeks now. It's the most important meeting of the day. And it turned into what was the most important meeting of the week, because we've been doing this every week for a long time, but it's every day. And we talk through, you know, what are we holding? What are we seeing? What are, you know, what are we hearing in the institution about different things? Like we started hearing about the immunity testing that we're going to start doing. I mean, we've got saliva testing that we can do to see if patients have the virus. And so how are those charges going to come through? Are we going to hold them? Is this part of the COVID-related no cost share stuff? How is that going to work? And it's, again, I think that, you know, Scott said it earlier, supporting our clinical operations. We've got clinical folks there. IT, Revenue Cycle can't exist without our IT folks, and having our Revenue Cycle operations meet every day to go over what's happening. And look at the data together and make good decisions. It's been fabulous. It's again one of the most important things that we've done to try to mitigate the risks for all of this. So, shameless plug. There it was.
Well, we talk about in the podcast like how they did it, and I think as a lesson, just like you're fortunate to have built a trusting relationships and a meeting structure that works amongst those three groups, which is not always the case. So I think, you know, you're probably really fortunate to have that in place already during a crisis. But a crisis can force that to happen too.
It does.
You know, you're in the spot, and people got to put aside their ego for a while, which Lord knows gets in the way, and a lot of times that can make things happen. That's interesting. Good stuff. Anybody else got anything they want to hit on, or?
I wanted to bring up Ben's 10-year challenge because listening to all of this makes me realize that this is really like a fevered microcosm of the troubles in Revenue Cycle, if you will, like the changes that need to be made. And so I wondered if each of you had maybe like either one big lesson learned or one thing that you've discovered like you really need to work on that could be a huge change for your organization.
Well, I can think of one off the top of my head. Kelly, nope. This is the hard part about being on the phone and not seeing you. You go first, Kelly.
Thank you, Heather. I mean, I think we kind of talked about it earlier, but just the ability to stand something up so quickly. I mean, it's a lesson learned that when you want to accomplish something or you're under the gun, that when you put your mind to it, you can do something pretty quickly, like get, 600 people working from home in a week. So being able to be that flexible and know that you can accomplish that, I mean, that's something huge to us, that when you have to look at challenges in the future, you can reflect back on this and say, hey, if we can knock that out, then we can obviously use those same principles and methodologies to move this forward as well. So it kind of just puts things in perspective that nothing's really too big if you put your mind to it to get it done.
I would say one of the main takeaways I've picked up, or it's re-emphasized, and this sounds like a motherhood and apple pie, a management 101 issue, but it really emphasized it, is the importance of communication. Timely, relevant, communication to everybody. And if you're not doing it face-to-face over video, smoke screen, jabber, whatever you want to do, that how important it is to get the relevant messages out to the right people in a timely manner. Because when folks feel like they don't know what's going on, even in an uncertain environment where imperfect information is available, they're not engaged, they're stressed out, they're isolated, they haven't bought into what you need to accomplish there. And regardless of the environment or how we go about messaging, the importance of doing that with great amounts of frequency, probably more frequency than we would otherwise do and think is important, needs to be there.
Absolutely. Heather, one last thought.
I would say that I think the biggest lesson that I learned is I think my revenue cycle leadership team and I have to continue to work more closely with the rest of the organization and educate them about how our work connects to them. Because what I saw was, we're already down a road and we're already doing a thing, and oh yeah, that's right, we need to probably get paid for that at some point, or we probably need to have compliant documentation around that. Oh yeah. And I know that this was more in the crisis mentality, but I find it often happening here that we've purchased something, or we've started a new service line, or we've done something, and it's sort of oh yeah, we forgot about the revenue cycle piece of all of that.
Yeah.
I saw that exacerbated big time with COVID, and I think we need to do a better job of getting engaged with those folks. It'll be harder if we're all working from home, but I think just putting it out there and asking to be involved and keeping our ear to the ground and trying to make sure that we're involved early on, because the cleanup is it's hard. And it would have been a lot easier if we knew what was coming. And I say that a lot here, but this just kind of really put me thinking about how I could do better, do a better job of having people understand what it is that we do and how we fit in with what they're trying to do. That was my takeaway. But I love Scott and Kelly's too. I want to be really a great communicator. We forget that part. I forget that part pretty often as I go through my day. So thank you, Scott, for reminding me.
Wow,
and
he
thank
is
you,
from
Kelly,
Duke, and they're doing it right.
I know, Duke is awesome. Duke's the best, right?
I knew
it was going to come out. And thank you, Kelly, for reminding us that we can do anything we want to do because we're awesome, right? Thank you for that.
Awesome, guys. Well, thank you so much for joining and giving your experiences to everyone. I think that's helpful. I think if you can join the town hall on Fridays at 4, that'd be awesome too, because that's been great hearing everyone's perspective and what challenges they have and positives and negatives. And so if you guys get a chance to be able to do that, it'd be awesome.
Absolutely.
Good deal. Thank you.
All right. Thanks, guys.
Thanks, everybody.
Thank you.